iMac.
iMac.
Huh. Okay, now it's audible, I guess. Yeah, sorted. Okay, done. Thank you, Aditya.
Okay.
Okay. So, guys, am I audible now? Give me a thumbs up if I'm audible. Now, also, I'm not audible. Then, audible, right? Okay, good. So, today we're going to talk about the pulmonary hypertension. And what is pulmonary hypertension? We'll try to understand the concept first and then we will go into the technical definition. Okay. So, we are familiar with what is called as systemic hypertension, right? What is the concept of systemic hypertension? You have elevated pressures inside the systemic blood vessels, systemic arteries. The arteries going to your different body parts, right? And then let me ask you a question. What is blood pressure first? I'm telling you systemic hypertension means elevated blood pressure in your systemic vasculature. Then what is blood pressure? So when blood moves, right, through the blood vessel, it moves as a column and this moving column of blood exerts lateral pressure on the walls of the blood vessels. So this lateral pressure exerted by the column of blood on the walls of the blood vessels is what we call as BP or blood pressure. So if this gets elevated in your systemic arteries, we call it as systemic hypertension. And if that gets elevated in your pulmonary arteries, the column of blood exerts higher pressure on the walls of the pulmonary arteries, we call it as pulmonary hypertension. Now, diagnosis of systemic hypertension is very easy, right? Catch hold of a superficial artery, tie a cuff around it, and try to take the pressure sufficient enough to compress it, and that is how you record the systemic blood pressure. Recording the blood pressure in the pulmonary artery is quite challenging. Okay, and then even if you are able to record, for the systemic hypertension, we have well-defined cutoff, right? What is the cutoff? If I'm recording the BP in clinic or in the hospital, if systolic is more than or equal to 140 or diastolic is more than or equal to 90, we will call it as hypertension, right? But when it comes to pulmonary artery pressures, first of all, non-invasive testing is not good investigation for recognition of the diastolic pressure in the pulmonary artery. We can somehow measure the systolic pressure in the echocardiography. And then with the systolic pressure alone, I cannot diagnose the pulmonary hypertension. So for that, we need the mean pulmonary artery pressure. So current definition of pulmonary hypertension is mean pulmonary artery pressure greater than, we usually abbreviate it as MPAP, mean pulmonary artery pressure, more than or equal to 20 millimeters of mercury. Now that begs a question. What is the normal mean pulmonary artery pressure? So please remember the normal MPAP in those who do not have pulmonary hypertension is approximately 14 millimeters of mercury plus or minus 3 millimeters of mercury at, again please note, I am emphasizing the word rest here, because just like your systemic BP, right, if I start doing exercise, my systemic blood pressure increases because my tissues need more blood supply to deliver that. Heart and blood vessels need to do more work, so obviously the blood pressure increases. Similarly, during exercise, pulmonary artery blood pressure also increases. So we have to measure it at rest. So normal mean pulmonary artery pressure is in the range of 11 to 17, that is 14 plus or minus 3 millimeters of mercury. Anytime it is more than 20 millimeters of mercury, it is associated with increased mortality risk. That is why MPAP more than or equal to 20 millimeters of mercury is used as the diagnostic cutoff for recognition of pulmonary hypertension. Okay, now coming to what can cause the pulmonary hypertension. So we have just understood that pulmonary hypertension refers to elevated blood pressure in your pulmonary artery, right? So pulmonary artery connects our right ventricle to the lungs. So when pressure in these vessels increases, we are calling it as pulmonary hypertension. In what all conditions the pressures in pulmonary artery can increase? So please remember the first and the most important point that you need to understand, the most common cause for pulmonary hypertension. Now I will give you an example. Let me say I have mitral stenosis. So my mitral valve opening is very narrow. And because of that, I may not be able to transfer the atrial blood to the left ventricle easily. So what will happen? As a result, pressure inside the left atrium starts increasing. Left atrial pressure starts increasing. So if the pressure inside the left atrium is high, can I drain the blood coming from the pulmonary veins into the left atrium easily? No, right? Because blood or fluid moves from higher pressure to lower pressure zone. So if I have to receive the blood from pulmonary veins to the left atrium, left atrial pressure should be lower than the pulmonary vein pressure. But if left atrial pressure is already high, then draining the blood from the pulmonary veins becomes difficult. So pressure inside the pulmonary vein starts rising. Why all this started happening? Because I have a narrow mitral valve opening. Once the pressure inside the pulmonary veins starts increasing, will it be easy for me to drain the blood from the lungs to pulmonary veins? No, right? So my right heart is pushing the blood into the lungs, but from the lungs, I'm not able to get that blood to the pulmonary veins because pressure in the pulmonary veins and the left atrium is already on the higher side. So and then pulmonary capillaries, the blood starts stagnating. This is what we call as pulmonary congestion. And this will lead to dyspnea. That's why when we talk about mitral stenosis, we talk about that dyspnea as a symptom. Okay. Now, once the capillaries in the lungs are so loaded with blood, what will happen to the pressure inside the capillaries? They're loaded with blood, so pressure increases. Now, if I have to push the blood from the pulmonary artery into this congested capillaries, my pulmonary artery pressure should exceed the pressure inside these capillaries. So obviously, I have to elevate the pressure inside the pulmonary artery. And when pressure inside the pulmonary artery increases, that is what we call as pulmonary hypertension. So why all this started? It started with mitral stenosis. Same applies to if I have conditions like left ventricular hypertrophy or mitral regurgitation or aortic stenosis or aortic regurgitation. In all these cases, eventually left atrial pressure increases, thus pulmonary vein pressure, thus congestion of the pulmonary capillaries resulting in pulmonary hypertension. So can I say that left heart disease can eventually lead to pulmonary hypertension? Yes. So the most common cause for pulmonary hypertension is left heart disease. Left heart disease. It may be valvular heart disease or left ventricular failure. Okay. What else can cause the pulmonary hypertension? Now, if I have a disease of the lungs, like lungs are getting fibrosed, or if there is severe hypoxia. So please remember, if there is hypoxia, less amount of oxygen is coming to the lungs. If that is the situation, then by default, your pulmonary capillaries will go into constriction. Why? Because if alveoli, see, this is an alveolus, this is supposed to receive the oxygen. And then on the other side, I will have the capillaries, which will take this oxygen and give it to the left side of the heart. But if oxygen only is not coming to the alveoli, then what is the point of giving blood to this capillary? Because this blood will go unoxygenated without receiving the oxygen if oxygen only is not coming to this alveoli. So the natural response from the body is that we will constrict this capillary. So when I constrict the capillaries, what will happen? Again, pressure inside the pulmonary artery will start increasing because these capillaries are constricted, pressure inside the capillary is high. So I have to push the blood with increased pressure. So anything that causes chronic lung dysfunction or chronic hypoxia can also cause pulmonary hypertension. Right? Can anybody name one common example of a chronic respiratory disorder which can cause pulmonary hypertension? One common respiratory disorder which can cause pulmonary hypertension. COPD, right? So when COPD starts causing pulmonary hypertension and thus eventually leads to other consequences, that is when we call it as cor pulmonale. So the second causes for pulmonary hypertension include chronic respiratory disorders, and hypoxia. Okay. What else can cause? Then there is an entity called as interstitial lung disease. Absolutely right. That can cause. COPD and interstitial lung diseases are leading causes for respiratory disorder induced pulmonary hypertension. Very good. ILD, yes, of course. ILD, one of the common causes for death in ILD after hypoxia. This was a last INI CET question. What is the most common cause for death in interstitial lung disease? The most common cause for interstitial lung disease is hypoxia. Hypoxia and its consequences. Second most common cause is right heart failure. Why right heart is failing? Because of development of pulmonary hypertension. Okay. And third, there is an entity called as pulmonary arterial hypertension. Pulmonary arterial hypertension. Now, what is the difference between the so-called pulmonary hypertension? That is what we are talking today, right? Pulmonary hypertension and pulmonary arterial hypertension. Pulmonary arterial hypertension, we usually abbreviate it as PAH, and pulmonary hypertension, we simply abbreviate it as PH. What is the difference? In pulmonary arterial hypertension, the pathology is not in the heart, left side of the heart. The pathology is not in the lungs. So without having a lung problem, without having a left heart problem, pressures inside your pulmonary artery are elevated. Then we call it as pulmonary arterial hypertension. This can be mostly idiopathic, just like systemic hypertension. See, systemic hypertension can happen because of endocrine disorders, like if you have pheochromocytoma or Cushing's disease, or if you have like renal artery stenosis. In all those cases, you can have systemic hypertension. Then you call it as secondary hypertension. But most of the people recognized with hypertension, they don't have a clear-cut identifiable cause, right? So such cases we call it as primary hypertension or essential hypertension. Similarly, pulmonary hypertension may happen in the absence of an identifiable secondary cause. Then we call it as pulmonary arterial hypertension. And this is the topic of contention because majority of the MCQs asked so far are centered around pulmonary arterial hypertension. So we will play little extra emphasis to this topic going forward. So again, to summarize, three major causes that you need to remember is left heart disease, which is the most common cause, then chronic respiratory disorders and hypoxia, and third one is something called as pulmonary arterial hypertension, which is nothing but an essential form of hypertension, primarily because of a problem in the blood vessel and nothing to do with lungs or the heart. Okay. Now, having understood this, we will come to the first important area of MCQ. How do you classify the causes for pulmonary hypertension? I just gave you a list, right? Now, WHO classifies the causes for hypertension into three groups. So here I'm going to enlist the WHO classification of causes for hypertension. I will come to that. WHO classification of pulmonary hypertension. So what WHO does is causes for pulmonary hypertension are put into 5 groups. Okay. So the first group, the group 1 is what we call as pulmonary arterial hypertension. Pulmonary arterial hypertension or PAH. PAH. Okay. So this you can also call it as the primary pulmonary hypertension, where you do not have an identifiable secondary cause. Okay. This is most likely going to be idiopathic, or it can be hereditary. And when it comes to hereditary, right, there is one important MCQ they ask you. What is the most common mutation responsible for hereditary form of pulmonary arterial hypertension? And this can also be because of connective tissue disorders. Then we call it as CTD related pulmonary arterial hypertension. Now, among these, CTD related is the most common cause. Okay. CTD related is the most common cause. Hereditary is due to mutation in a gene called as bone morphogenic protein receptor 2, BMPR2 gene mutation. Now this gene, the BMPR2 gene, is part of, if you are in first year MBBS, you might remember there's something called as transforming growth factor beta signaling pathway. So this is part of the TGF beta signaling pathway, which is concerned with the blood vessel tone and proliferation of the endothelium. Okay. So pulmonary arterial hypertension can be idiopathic, hereditary, or it may be associated with connective tissue disorders. And when it comes to association with connective tissue disorders, they will ask you what is the most common CTD associated with pulmonary arterial hypertension. Can anybody give the answer to this? This is the repeatedly asked MCQ. See, what are CTDs? Connective tissue disorders. So under that, you have two categories. One, inherited connective tissue disorders, and the other one, acquired connective tissue disorders. Inherited means your disorders like the Ehlers-Danlos syndrome or the osteogenesis imperfecta. Those are inherited connective tissue disorders. Acquired are mostly autoimmune, like rheumatoid arthritis, SLE, scleroderma, Sjogren's syndrome. These are all acquired connective tissue disorders. Wazir said absolutely right. So the most common connective tissue disorder which is associated with pulmonary hypertension is going to be scleroderma. Scleroderma. In fact, the most common cause for death in patients with scleroderma is pulmonary hypertension itself. So if they develop pulmonary hypertension, eventually right heart failure, and they die because of it. Okay. Wazir said, can you mention mountain life? Yes, SLE can also be associated with pulmonary hypertension. So when it comes to most common, it is scleroderma, but even SLE can be associated. So Wazir Said, I have a question. So when we talk about scleroderma, right, there are two subtypes. One is limited cutaneous and the other one is diffuse cutaneous. Which one is more likely to be associated with pulmonary arterial hypertension? Is it limited cutaneous or the diffuse cutaneous? So Tapa, it is a connective tissue disorder or an autoimmune disorder where your immune system starts damaging your own tissues. And in scleroderma, there is primarily the most commonly affected tissue is skin. So because of that, they start losing the skin elasticity. The skin starts becoming tighter and tighter, mainly affecting the distal parts of the body, that is hands and feet. So that is why these patients often present with Raynaud's phenomenon. Whenever they put their hand into cold water, it causes pallor, numbness, and tingling sensations. But scleroderma is not only affecting the skin, it also affects the blood vessels. It causes vasoconstriction, and because of that, these patients develop pulmonary hypertension. Good. No, it is not the diffuse cutaneous. It is the limited cutaneous variant. Diffuse cutaneous is usually known to cause interstitial lung disease. And when interstitial lung disease causes pulmonary hypertension, we don't call it as pulmonary arterial hypertension. To call it as pulmonary arterial hypertension, there should be no involvement of lungs and left heart, right? Let me write it down so that you remember. In pulmonary arterial hypertension, no involvement of lungs or the left heart. So hypertension in the pulmonary vessels is not because of left heart disease or lung pathology. Without these, there is elevated pulmonary hypertension. And that is typically more common in the limited cutaneous variant. Diffuse cutaneous can cause pulmonary hypertension, but that is because diffuse cutaneous causes the ILD. So lungs get affected first, and then because of the lung involvement, you develop pulmonary hypertension. Right, CREST syndrome. The limited cutaneous is often addressed as CREST syndrome. Okay, very good. Chetan Kumar, I'm coming to that. I'm coming to that. Okay. Now, what comes under group 2? What comes under the WHO group 2? Okay, Chetan Kumar, I'll address your point. Okay. So, we place the lung diseases and hypoxia as a cause for pulmonary hypertension in group 3. Now, why are they becoming the reason for development of pulmonary hypertension? So let me say this is the lung. Okay. Now, how blood comes to the lung? From the pulmonary artery, right? Now, this pulmonary artery is actually coming from your right ventricle, and in the level of lungs, let me say there is an alveolus. So this pulmonary capillaries, the pulmonary artery forms capillaries around the alveoli, and from there the blood goes to the left side of the heart, that is your left atrium, through pulmonary veins. So these are my pulmonary veins. This is left ventricle, this is right ventricle, and this is pulmonary artery. Okay. Now, in conditions like interstitial lung disease, what happens? The lungs get fibrosed. There is fibrosis of the lung. Now, this fibrosis primarily affects the alveoli and the surrounding connective tissue. But when that happens, they distort the pulmonary capillary architecture. So because of the distortion, they will limit the flow through the pulmonary capillaries. So if I am not able to allow the flow of blood through the pulmonary capillaries, then obviously pressure inside the pulmonary artery starts building up. That is how I end up developing pulmonary hypertension in interstitial lung disease. Okay. Now, when it comes to COPD, you come across the term called as emphysema. What emphysema refers to? Irreversible dilatation of the alveoli. So these alveoli are irreversibly dilated. So again, when alveoli dilate, they are literally stretching and distorting the pulmonary capillaries, again limiting the flow through these pulmonary capillaries, resulting in elevated pulmonary artery pressure. But I also made a statement, right? It is not just the chronic respiratory disorders. Even hypoxia can cause pulmonary hypertension. That is how that happens. If less amount of oxygen is coming to the alveoli, then by natural mechanisms like involvement of endothelins, we will cause pulmonary vasoconstriction. Because if this alveoli is not ventilated, then it is better not be perfused also. Because if this alveoli doesn't get air and the blood comes to this capillary and then goes to the left side of the heart, this is going without being oxygenated. Obviously, the body's physiology doesn't want that. So it will cause the constriction of this pulmonary capillary. And once the capillaries are constricted, obviously they will limit the flow through them. And again, the pressure inside the pulmonary artery starts building up. Clear? Okay. So this comes under the group 3. What comes under group 2 of the pulmonary hypertension is pulmonary hypertension due to left heart disease. Pulmonary hypertension due to left heart disease. So under that, you can have valvular heart diseases like aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, as well as left ventricular failure. And that is why in the bedside discussion, often teachers tell you that the most common cause for right heart failure is left heart failure. Anything that increases the pressure in the left atrium will eventually lead to pulmonary hypertension and then eventually the right ventricular dysfunction. Okay. So WHO group 3 has pulmonary hypertension due to respiratory disorders or hypoxia. Okay. Then fourth is something called as chronic thromboembolic pulmonary hypertension. Thromboembolic pulmonary hypertension, usually abbreviated as CTEPH. CTEPH. Okay, now what is this entity? You have come across the term called as embolism. Most of you have come across the term called as embolism. What does that mean? A clot is formed somewhere in your circulatory system. It gets dislocated from there and moves and goes somewhere else and gets stuck there. This phenomenon is what we call as embolism. So if a clot is formed, let me say in the left atrium, the clot from the left atrium generally goes to left ventricle, from the left ventricle to aorta, from the aorta through carotid artery, it may go to the middle cerebral artery and cause stroke. Now this is obviously affecting the systemic circulation, so I will call it a systemic embolism, right? Similarly, I can form a clot in the popliteal vein or the femoral vein, right? So if I form a clot in the lower limb or the upper limb deep veins, from the venous side where the clot will travel to, like if I form a clot in the popliteal vein, it will go to femoral vein, from the femoral vein to iliac vein, from the iliac vein to inferior vena cava to the right atrium, from right atrium to right ventricle, from right ventricle to pulmonary artery. So it may block the main pulmonary artery or one of its branches or its subsequent branches. In that case, we call it as pulmonary embolism. If it happens all of a sudden, acutely, then it is acute pulmonary embolism, which in itself is a separate topic that we will be discussing. And in surgery also, they will discuss along with deep vein thrombosis. Okay. But what if I get a clot in one of the lower limb veins and this does not get dislocated all at once? It starts fragmenting and small pieces travel through the venous system, go and get stuck in the pulmonary capillaries. Small pieces happening throughout, like for many weeks or months together. Then what happens is multiple of your capillaries in the pulmonary vasculature are getting clogged with these tiny clots. If whole clot gets dislocated and then goes and blocks one of the blood vessels, it is an acute emergency and that is treated differently. Like if I have to treat this, I have to give thrombolytic agents to dissolve this clot, right? But if I have small shower of clots in the pulmonary vasculature, which happens over several weeks to months, in that case, slowly the capillaries are getting clogged. So pressure inside the pulmonary artery will start rising up. So this condition is what we call as chronic thromboembolic pulmonary hypertension, which we have placed in category 4 or group 4. Then we have group 5, which primarily refers to miscellaneous, means anything that does not fit into the above four categories. If I have a patient with pulmonary hypertension which cannot be explained as pulmonary arterial hypertension, or because of left heart disease, or because of respiratory disorder, or chronic thromboembolic pulmonary hypertension, then we put it in group 5. Okay. Now, one of the MCQs that they ask you at INI CET level is, in pediatrics you come across these very complex congenital heart diseases, right? Not like simple aortic stenosis, mitral stenosis, or mitral registration. Complex congenital heart diseases. Where should we place them? Because in those complex congenital heart diseases, both right and left side of the heart is involved, right? So there may be even the pulmonary artery abnormalities. So where should I place it? Should I count it as group 2, or should I place it in group 5? So please remember, group 5 includes complex congenital heart diseases. Complex congenital heart diseases should be placed in group 5. Like for example, tetralogy of Fallot, right? Tetralogy of Fallot may result in pulmonary hypertension. If that is the case, it should come under group 5. Okay. So grouping is very simple. Group 1, pulmonary arterial hypertension. 2, pulmonary hypertension due to left heart disease. 3, respiratory disorders or hypoxia. 4, chronic thromboembolic pulmonary hypertension. 5, all other causes. Okay. So now we have understood the grouping also. Now let us look at the clinical features. What will happen if pulmonary hypertension is there? So let me tell you one important statement. 10 millimeters increase in MPAP over and above normal is associated with 2.7 times increase in mortality. So if you have pulmonary arterial hypertension or pulmonary hypertension due to whatever cause, your death risk is significantly going to be higher. Okay. So now what consequences a pulmonary hypertension can lead to high mortality increases? So let me say a particular person has developed pulmonary hypertension. Okay. Whatever may be the reason, it may be pulmonary arterial hypertension, left heart disease, lung disease, hypoxia, thromboembolic pulmonary hypertension. He has developed pulmonary hypertension. So what does that mean? It means pressure inside your pulmonary artery is high. What is the consequence of this? So if the pressure inside the pulmonary artery is high, there are two possible consequences. First one, if I have to push the blood from the right ventricle to the pulmonary artery whose pressure is already high, then right ventricular pressure should be even more higher, right? Then only I will be able to push the blood into the pulmonary artery. If I cannot generate pressure sufficient enough to exceed the pressure in the pulmonary artery, then I cannot eject the blood. So obviously right ventricle will not keep quiet. It will try to generate more force by strong contraction. And if it goes on doing it repeatedly, obviously it is doing a lot of work, right? So it will develop hypertrophy. So pulmonary hypertension can lead to right ventricular hypertrophy. Now when we talk about hypertrophy, there are two terms. One is called as concentric hypertrophy. The other one is called as eccentric. So can anybody tell me what kind of hypertrophy I can expect when we have pulmonary hypertension? Ventricular workload is increased, all of us agree. And when it comes to cardiology, there are two types of ventricular workload. One is called as preload, the other one is called as afterload. So what is increase in a patient with pulmonary hypertension? Is it preload or afterload? What do you think? Sutapa Samantha, the scleroderma, depending on the extent of skin involvement. See, in scleroderma, it is there in the name. Derma means skin, sclerosis means fibrosis or hardening of the skin. So in scleroderma, there is skin fibrosis or hardening. If that is restricted to only distal most part of the body, right, not exceeding proximal to the elbow, then we call it as limited cutaneous. And if the skin fibrosis is exceeded proximal to the elbow, started from the distal part, then it has progressed to the region proximal to the elbow joint, then we call it as diffuse cutaneous. Right, it is the afterload. What is afterload and preload? Preload is the amount of blood that is present at the end of diastole in a ventricle. See, remember, in the diastole, we fill the ventricles from the blood coming from atria, and in the systole, we eject it to the respective arteries. So if I fill more blood into the ventricle, ventricle needs to do more work to eject it, right? जितना मैं ज़्यादा भरूंगा ventricle में, उतना ज़्यादा काम करना पड़ेगा. That is what we call as preload. एंड प्रीलोड इज नथिंग बट इक्वल टू व्हाट वी कॉल एज एंड डायस्टोलिक वॉल्यूम, मतलब डायस्टोल के एंड में वेंट्रिकल में जितना ब्लड है दैट इज एंड डायस्टोलिक वॉल्यूम। वो कितना बढ़ेगा उतना ही वेंट्रिकल को ज्यादा काम करना पड़ेगा, राइट। जस्ट टू गिव यू एन एग्जांपल, दिस इज 1 liter bottle. If I have to push 1 liter up, I need to do some amount of work. Instead of that, I take a 2 liter bottle. If I have to push that up, I need to do more work, right? Simple. So जितना end diastolic volume ज्यादा होगा ventricle का काम उतना ज्यादा होगा. This is what we call as preload. But if I have to push this bottle up, and if there is something restricting its movement, it is going to give resistance to its movement. See, for example, अगर इस बॉटल को खुले एयर में पुश कर रहा हूं तो आई डोंट हैव मच रेजिस्टेंस, बट व्हाट इफ आई एम इनसाइड a swimming pool and then I'm trying to push it, the water is going to offer the resistance, right? So the resistance against which I need to push, we call it as afterload. So in the level of heart, who is going to give the resistance to the ventricles? The resistance can come from the valves, right? Like left ventricle can face resistance from aortic valve, or the right ventricle can face resistance from the pulmonic valve if the valve is dysfunctional. अगर valve ठीक है तो it does not cause any resistance, but the blood vessels will definitely give some resistance. So pulmonary artery does give some resistance, and that is what we call as afterload. The resistance offered by the pulmonary artery to the flow of blood, we call it as afterload. For the left ventricle, afterload comes from the resistance given by the aorta for the flow of blood. But once we have pulmonary hypertension, pressure inside the pulmonary artery is high, so this is going to offer more resistance. So increased resistance is equal to increased afterload. So when we have pulmonary hypertension, there is increase in the afterload. Increased afterload. I think some of you had already commented it. Absolutely right. There is increase in the afterload. And whenever afterload increases, what kind of hypertrophy we get? Right. Wazir said absolutely right. So afterload is nothing but a pressure resistance or the pressure. So when we try to work against the pressure, we develop what is called as concentric hypertrophy. So there are two terms, concentric and eccentric. So for example, if the preload is increased, मतलब मैंने वेंट्रिकल में बहुत सा ब्लड भर दिया है, अब इसको एजेक्ट करने के लिए वेंट्रिकल ज्यादा काम कर रहा है, उस टाइम पे मैं मसल की थिकनेस अंदर की तरफ नहीं बढ़ा सकता, बिकॉज इफ आई इंक्रीज द मसल थिकनेस इनवर्ड्स, देन द वेंट्रिकुलर कैविटी विल बिकम स्मॉलर. फिर जगह कहाँ बचेगा? जो एक्स्ट्रा वॉल्यूम में हैंडल कर रहा हूँ उसके लिए जगह नहीं बचता है. So whenever the preload increases, I add the muscle mass outside. So thickness तो increase हुआ, लेकिन muscle mass outside add हुआ है, अंदर का cavity size decrease नहीं होता है. This is what we call as eccentric hypertrophy, adding the muscle mass outwards. But when we have increased resistance against which I need to eject the blood, I am not worried about the cavity size. So I add the muscle inwards. तो मसल का थिकनेस तो इंक्रीज हुआ बट कैविटी का साइज छोटा हुआ. दिस इज व्हाट वी कॉल एज कॉन्सेंट्रिक हाइपरट्रोफी. सो पल्मोनरी हाइपरटेंशन बीइंग अ कंडीशन वेयर देयर इज इंक्रीज आफ्टर लोड, आई विल डेवलप कॉन्सेंट्रिक राइट वेंट्रिकुलर हाइपरट्रोफी. What consequences this will lead to when I develop the concentric right ventricular hypertrophy? As I go on adding the muscle inwards, the ventricular cavity size is becoming smaller. It is becoming smaller, and all of us know that we transfer the blood from atria to ventricles mostly passively. See, 70% of blood transfer from atria to ventricle happens during what is called as passive filling, and 30% happens because atria contracts, what we call as active filling. तो ये 70% तो passive filling पे dependent है, right? Absolutely dependent on passive filling. और पैसिव फिलिंग कैसे होता है? एट्रियल प्रेशर इज हायर देन द वेंट्रिकुलर प्रेशर, एंड बिकॉज ऑफ द प्रेशर ग्रेडियंट ब्लड मूव्स फ्रॉम एट्रिया टू वेंट्रिकल. दैट इज हाउ वी अचीव द पैसिव फिलिंग. बट व्हेन वेंट्रिकुलर कैविटी बिकम्स स्मॉलर, व्हाट हैपेंस टू द प्रेशर इनसाइड द वेंट्रिकल? सिंपली अप्लाई द बॉयल्स लॉ. व्हाट बॉयल्स लॉ सेज? प्रेशर इन अ चेंबर इज इनवर्सली प्रोपोर्शनेट टू इट्स वॉल्यूम. तो जैसे मैंने वॉल्यूम कम किया, प्रेशर इनसाइड द वेंट्रिकल इंक्रीज हो गया. मुझे पैसिव फिलिंग करने के लिए एट्रिया का प्रेशर शुड बी मच हायर देन द वेंट्रिकुलर प्रेशर, तब ब्लड मूव करेगा एट्रिया से वेंट्रिकल. लेकिन वेंट्रिकल की कैविटी साइज छोटे करते इसका प्रेशर बढ़ गया, तो द प्रेशर डिफरेंस बिटवीन द टू इज मिनिमल. तो हम थोड़ा बहुत ही प्रेशर ब्लड ट्रांसफर कर पाएंगे पैसिव फिलिंग के टाइम पे। तो फिर क्या होगा, इफ आई एम नॉट एबल टू ट्रांसफर द ब्लड एफिशिएंटली फ्रॉम एट्रिया टू वेंट्रिकल, फिर राइट एट्रिया के अंदर प्रेशर बढ़ने लगेगा. इफ प्रेशर इनसाइड द राइट एट्रियम स्टार्ट्स इंक्रीजिंग, then can I drain the blood coming from superior and inferior vena cava? No. So pressure inside the superior and inferior vena cava will start rising. So when pressure inside the superior vena cava rises, our JVP will become elevated. When pressure inside the inferior vena cava rises, we will develop congestion in the liver, ascites and pedal edema. This is what we generally describe, right, whenever we talk about right heart failure. So pulmonary hypertension leading to concentric right ventricular hypertrophy will result in increased right atrial pressure. ऐसा क्यों हो रहा है? Because I'm not able to transfer the blood efficiently from right atrium to right ventricle, because right ventricle का pressure already high हो चुका है by concentric right ventricular hypertrophy. So that will result in rise in the JVP, congestive hepatomegaly, ascites and pedal edema. Ascites and pedal edema. And when these symptoms appear, what do we call it as? We will call it as right heart failure. So pulmonary hypertension can lead to right heart failure. Okay. Now, second thing, when we develop concentric right ventricular hypertrophy, ventricle के muscle mass increase हो गई है. So now, will it require more blood to be able to work or less blood? Obviously, more muscle, it will require more blood. If I'm not able to give, then the right ventricle starts developing ischemia. And what symptom I can expect if I start developing ischemia? So concentric RVH means increased myocardial oxygen demand. It will need more oxygen. And if it is requiring more oxygen, if I'm not able to give it to the ventricle, then I can develop ischemia. And when I develop ischemia, what kind of symptoms I can expect? Chest pain, which we usually describe as angina. So can we get chest pain in patients with pulmonary hypertension? Yes, why not? Okay. So that's not the only problem. What other problem I can expect? So I just told you, right? Once I develop the concentric right ventricular hypertrophy, the ventricle size has become smaller. So the amount of blood I can transfer to the ventricle during diastole has significantly come down. I will not be able to transfer the same amount of blood I could transfer when I have a normal sized ventricle. So if I'm able to fill less quantity, and second thing, your pulmonary artery pressure is already high, so that is also going to offer the resistance to the flow of blood from right ventricle to pulmonary artery. So then, can I say that the amount of blood that I eject from the right ventricle into pulmonary artery is going to come down? For two reasons. One, first of all, I am filling the right ventricle less. Second, my pulmonary artery is offering resistance to the flow of blood. So the amount of blood coming from the right ventricle comes down. That in more sophisticated terms, I would describe as decreased right ventricular output. Decreased right ventricular output. So if less amount of blood comes to the heart, right, obviously less amount of blood is getting oxygenated at any given point of time. So this can result in hypoxia and a perception of shortness of breath or dyspnea. So this can result in dyspnea and hypoxia. And we already know that whenever hypoxia happens, even there can be pulmonary vasoconstriction, which will worsen the pulmonary hypertension further. Second thing, how blood comes to the left atrium? Obviously, whatever right ventricle sends, that blood only comes to left atrium. So if right ventricle is able to send lesser quantity of blood to the lungs, then lesser quantity of blood will come to the left atrium. If less quantity of blood comes to left atrium, less quantity comes to left ventricle. If less quantity comes to left ventricle, obviously what I can eject into the aorta will also be less, right? So pulmonary hypertension, if there is decreased right ventricular output, there can be decreased left ventricular filling. That is nothing but decreased left ventricular and diastolic volume. This can result in decrease in the left ventricular stroke volume. Left ventricular stroke volume. And if I'm able to eject lesser quantity of blood into the aorta, obviously my tissues are going to suffer from the lack of blood supply to them, right? So what symptoms I can expect See, can I say that if the stroke volume decreases, there is decrease in the cardiac output? Because we know stroke volume is nothing but cardiac output is nothing but stroke volume into heart rate. So decreased cardiac output can lead to symptoms like fatigue, a very common symptom because my tissues are not getting sufficient blood. I will not be able to feel energetic like a normal individual. Second, if my brain doesn't get sufficient blood, it may go blank transiently, and that is what we call as syncope or syncope. So can I get syncope in patients with pulmonary hypertension? Yes. Fatigue? Yes. Shortness of breath? Yes. Hypoxia? Yes. Features of right heart failure? Yes. So these are all symptoms of pulmonary hypertension. Now the MCQ they will ask you is what is the most common symptom of pulmonary hypertension? The most common symptom of pulmonary hypertension is going to be dyspnea. Shortness of breath is the most common symptom that these patients come to hospital with. Okay. Now, among these, what symptoms you count as the markers of severity of pulmonary hypertension, which say that patient has very high risk of death? So, if he has developed syncope, right heart failure, or angina as symptoms, these indicate that he has got severe pulmonary hypertension. Dyspnea is one of the earliest symptom. Okay. Okay, so these are the symptoms. Now, on examination, what findings I can expect, right? Let me take you back to the pathophysiology. What we learned from the pathophysiology, we just learned that there is development of concentric right ventricular hypertrophy. There is elevated right atrial pressure, and there is elevated JVP, congestive, hepatomegaly, and other features of right heart failure, right? So, keeping that in mind, tell me what findings I should expect on inspection, palpation, and auscultation. So obviously on inspection, we will see raised JVP. But merely knowing that there is raised JVP is not enough. We should be able to tell what happens to the JVP waveforms. So in the JVP waveforms, first thing that you would expect is a prominent or a tall A wave. Can anybody tell me what is the reason for A wave to appear on the JVP? Then we will be able to understand why we get a prominent A wave. Or let me ask it in a different way. Wazir said, very good, very good. Let me ask it in a different way. Which phase of cardiac cycle A wave corresponds to? A wave corresponds to. So we can have prominent A wave, prominent V wave, and there is something called as Lancisi sign on the JVP. What is Lancisi sign? Fusion of C and V waves. Okay, so if you're not able to understand now, don't worry. I will be doing a detailed session on the JVP where we will try to understand the JVP, all the waveforms in relationship with the cardiac cycle. Right, it is because of the atrial contraction. That is nothing but active filling phase, right? As I told you, transfer of blood from atria to ventricle happens in two phases. First, 70% transfer in passive filling, where atria is not contracting. Just because the ventricular pressure was low, the blood was moving from atria to ventricle. After that, for the remaining 30%, atria actively contracts to push that blood. That phase is responsible for the A wave. Why? Because when atria is contracting, what is happening to the size of the atria? It is decreasing. And what Boyle's law says? If the volume is decreasing, pressure will increase. So when pressure increases inside the atria, pressure increases in the jugular venous pulsations also. That is why we get a rise in the pressure. That is A wave. Now, if already right ventricle is very small and stiff, then atria has to contract more to push the blood. So obviously, the height of the A wave will increase. So that is why you're getting the prominent A wave. Okay. Then on palpation, see, please remember when we develop pulmonary hypertension. In fact, this is a very important bedside discussion point. How do you recognize pulmonary hypertension in a patient with valvular heart disease? You should give them two answers. One is palpation finding, the other one is auscultation finding. Whenever we have pulmonary hypertension, P2 becomes quite loud. P2, that is because of the closure of the pulmonic valve, the sound becomes quite loud, the P2 component of the second heart sound. And that can be loud enough for us to even feel it. So you may have a palpable P2. I think Wazir had already mentioned about it. We can have a palpable P2. Not just that. Look at the pathophysiology. We have developed the concentric right ventricular hypertrophy. So this hypertrophied right ventricle, when it contracts, it can give rise to parasternal pulsation, right? We call that finding as right ventricular parasternal heave. Right ventricular parasternal heave. Right ventricular parasternal heave. So these are the two findings you may expect on palpation. Then when it comes to auscultation, you can hear a loud P2. You can hear a loud P2. This loud P2 itself is what we are palpating as a palpable P2. Okay. Now, I forgot to tell you one more point. This concentrically hypertrophied left ventricle obviously needs more and more blood supply, and I may not be able to meet its demand. So when I'm not able to meet its demand, slowly what happens is some areas here will start becoming ischemic, right? They start developing micro infarcts, and as they start developing the micro infarcts, was it say it's very good, very good. So as they start developing micro infarcts, the infarcted tissue is nothing but necrosed and atrophied, right? So the ventricle starts thinning. It was muscular, but now it is not getting blood supply, so slowly it starts thinning. So when eventually it will become thinned out, and then it will become dilated. So we can have right ventricular dilatation in the long run. And when it becomes dilated, so please remember, if you go back to your anatomy, what you notice is this tricuspid valve. This tricuspid valve is actually inserted into the wall of the ventricle like this. So if I stretch the ventricle, see, if this is the ventricle, this is where you have the tricuspid valve. This is where I have the pulmonary artery going out. Now, if I start stretching it, then even the valve will be pulled apart. And when the valve gets pulled apart, the leaflets will move apart, leaving a gap in between through which the blood can start regurgitating. So, pulmonary hypertension can lead to tricuspid regurgitation. So, this ischemia can also leads to right ventricular dilatation, and right ventricular dilatation can lead to what we call as functional tricuspid regurgitation. Why are we calling it as functional TR? Because the valve has no problem. Valve is not pathological. It is the dilatation of the right ventricle which has stretched the valve leaflets to move away, making a gap in between and through which the regurgitation is happening. So we can have functional TR. So on auscultation, we can also hear the murmur of TR if there is tricuspid regurgitation has started happening. And I think Wazir had mentioned one more important point. If you know the heart sounds, you will probably understand. Normally, we hear sounds because of the closure of the valves, right? When pulmonary and aortic valve close, they produce A2P2, and that is combined, we call it as S2. And when mitral valve, tricuspid valve close, they produce M1 and T1, and we call it as S1. Opening of the valves generally does not produce the sound until and unless valve is pathological. Like if I have aortic stenosis, it may produce a sound. When it opens, we call it as click. If I have mitral stenosis, while opening, it may produce a sound. We call it as snap. But the normal valves, when opening, they do not produce a sound. Only closure produces a sound. But when blood moves from one chamber to other chamber, right? This movement of blood normally does not produce a sound. But if I have changed the ventricular dynamics, it can produce a sound. For example, when I forcefully push the blood into a stiff, concentrically hypertrophied ventricle, it can produce a sound. We call that sound as S4. And if I have a dilated ventricle and blood moves during the active filling into this large chamber, it can produce a sound. We call it as S3. So here to start with, we had concentric LVH, right? So we may also have a S4. We may hear a S4. And please remember, if you start hearing S3 in a patient with pulmonary hypertension, S3 happens when you have dilated ventricle. So it indirectly tells you that it is a very severe case of pulmonary hypertension, because dilatation is going to happen when you have long-standing ischemia, right? Okay, so that is about the auscultation. Now coming to the real crux. How do we evaluate a patient, right? Patient presented with dyspnea. We examined and we found that there is raised JVP, or we had a palpable P2, loud P2, S4 from the right ventricle, or maybe murmur of TR. What is a murmur of TR? That is pansystolic murmur, right? Murmur of TR is pansystolic murmur. I started suspecting that, okay, this may be a case of pulmonary hypertension. Now, how do I take it from there to the diagnosis? On a suspected case, initial evaluation will primarily focus on ECG and two-dimensional echo. Now, what can I find on the ECG? Obviously, ECG can help me to identify two things. One, ECG can help me to identify the concentric right ventricular hypertrophy. And when right atrial pressure increases, even right atrium becomes dilated. That I can identify on the ECG. So ECG can help me to recognize right ventricular hypertrophy. And when right atrium gets enlarged, we develop a tall P wave. We call it as P pulmonale. Now, what echo can help me to? Can I measure the pulmonary artery pressure from the echocardiography? Directly? No. Because we cannot properly visualize it to first take the pressure readings. But pulmonary artery pressure and right ventricular pressure during systole are generally same. So we can measure the right ventricular pressure and presume it to be pulmonary artery pressure. But we can only measure the systolic pressure, because the diastolic pressure between pulmonary artery and right ventricle are not going to be same. So this can help us to record the right ventricular systolic pressure, and we will count it as equivalent to pulmonary artery systolic pressure. We will call it as PASP, pulmonary artery systolic pressure. Okay. So from systolic pressure, if it is high, I can again suspect that this individual may be having mean also high, but I cannot calculate the mean pulmonary artery pressure from the right ventricular systolic pressure, or the PASP. So for that, what is the ideal investigation? These are only the initial footing where you can consolidate that your suspicion is in the right direction. For confirmation, we need to do invasive testing. I need to put a catheter into the right side of the heart, right? Put a catheter into the right side of the heart, measure the right ventricular pressure, measure the pulmonary artery pressure, and then this procedure will also help you to measure the pressure inside the pulmonary capillaries through what is called as pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure. So that this procedure will help you to confirm you have pulmonary hypertension, and it will help you to rule out if you have a heart disease. So that is why right heart catheterization is going to be the investigation of choice. RHC, or right heart catheterization, is the investigation of choice. So Tapa, I will be doing ECGs also. We will understand that little better when we start ECG. P pulmonale refers to tall P waves. So normally inside the ECG, every wave has a fixed normal range of amplitude and the normal duration. So when the amplitude or the height of the P wave is more than normal height is less than 2.5 small squares on the ECG. If it is more than that, then we call it as P pulmonale. That indicates there is right atrial enlargement. That can happen in various conditions. One of the conditions is also pulmonary hypertension. Okay. Now, when I do right heart catheterization, right, I have to be able to interpret that data. At the INI CT level, they ask you to interpret the right heart catheterization data. Now, what measurements I get from the right heart catheterization? First one, I can measure the mean pulmonary artery pressure. I can measure the mean pulmonary artery pressure. Second thing, I will measure something called as pulmonary capillary wedge pressure. And the third one is pulmonary vascular resistance. Please bear few minutes to understand this concept, because this is very crucial. Last 3 or 4 years, they've asked a lot of questions on pulmonary hypertension, and most of them loiter around either the WHO classification of groups or the interpretation of right heart catheterization data. So I'll tell you what we do in the right heart catheterization. So I've reached the right atrium with the catheter through the jugular vein. From there, we go to the right ventricle. We measure the right ventricular systolic pressure. Then we advance it to the pulmonary artery, and we take the measurements from the pulmonary artery, the systolic, diastolic, and the mean pressure. So that is our mean pulmonary artery pressure. Now this catheter will be further advanced through the branches of pulmonary artery till I reach a point where I can no longer push the catheter. That usually happens when I have reached closer to the pulmonary capillaries. When I've reached almost here, it gets stuck. I cannot advance it any further. I will take the readings from this position, this location. This pressure is what we call as pulmonary capillary wedge pressure. So it indirectly tells me about the pressures in the pulmonary capillaries. I can presume that if pulmonary capillaries are fine, then it indirectly tells me about the pressure in the pulmonary veins, right? And the pressure in the pulmonary veins generally go up when pressure inside the left atrium goes high. So this pulmonary capillary wedge pressure, I can say it is an indirect marker of the left atrial pressure. So if left atrial pressure is high, pulmonary capillary wedge pressure will be high. So if pulmonary capillary wedge pressure is high, I can presume that patient has got the left heart disease as the cause for pulmonary hypertension. If only MPAP is high and pulmonary capillary wedge pressure is normal, then there is no left heart disease. The problem may be in the lungs or in the pulmonary artery. Very good. Then the third thing we measure is something called as pulmonary vascular resistance. It is the resistance of the pulmonary artery. If the problem is in the pulmonary artery itself, there is pulmonary arterial constriction, then obviously the pulmonary vascular resistance will be increased. So these three parameters we will take into account. Now let us look at its interpretation. So when we do right heart catheterization, first thing is to call it as pulmonary hypertension is equal to mean pulmonary artery pressure more than or equal to 20 millimeters of mercury. तभी तो हम pulmonary hypertension diagnose करेंगे. उसके बाद में we will be looking at the pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure normal is less than 15 millimeters of mercury. So if it is less than 15 millimeters of mercury, that means it is normal. So there is no left heart disease. Left heart में कोई problem नहीं है. So in such case, we will diagnose the case as pulmonary arterial hypertension. And in pulmonary arterial hypertension, obviously the pulmonary vascular resistance will be high, more than 3. Wazir said, very good, very good. Okay. On the other hand, if I get pulmonary capillary wedge pressure, which is more than or equal to 15 millimeters of mercury, that indicates that probably there is increased pulmonary vein pressure, maybe increased left atrial pressure. Okay. So in such case, again we need to take one more step. We have to look at the pulmonary vascular resistance, whether it is more than 3 or whether it is less than 3. Okay, so please look at the image that we had just sketched. So if I have pulmonary capillary wedge pressure taken from the point where catheter is no longer further possible to advance. So that is indirectly telling me the pressures in the capillaries. That is why we are calling it as wedge pressure. Means I'm wedging it into the point where I cannot push it anymore and I'm taking the pressure there. That is pulmonary capillary wedge pressure. So if that is high, there are two possibilities, right? Either you have the problem in the pulmonary veins, pressure is high there because it is occluded, or left atrial pressure is high. Most commonly it will be left atrial pressure that will be high. Now how do I differentiate whether it is only the pulmonary vein that is being affected or it is the left heart that is being affected, resulting in pulmonary vein pressure elevated? So when left heart gets affected, right, like patients with left ventricular failure or aortic stenosis, there will be upregulation of what we call as RAS, renin angiotensin aldosterone system. So out of that, one of them is angiotensin 2. Angiotensin 2 is a vasoconstrictor. So this angiotensin 2 will cause pulmonary vasoconstriction, and because of that, pulmonary vascular resistance will increase. So if I have PCWP elevated and pulmonary vascular resistance also elevated, then it is left heart disease. That clearly tells that there is role of RAS. But if only PCWP is elevated, but pulmonary vascular resistance is not elevated, then pulmonary veins are occluded. Clear? So if the pulmonary vascular resistance is more than 3, it indicates you have a pathology. Vajir, I will address it in your words. When we divide these causes for pulmonary hypertension, we also come across these terms called as post-capillary, pre-capillary. So what do I mean by post-capillary? Post-capillary, see, this is our pulmonary capillaries. To call as a post-capillary cause for pulmonary hypertension, the pathology should be after the capillaries, that is in pulmonary veins or the left heart. And to call it as pre-capillary, either it should be at the level of lungs or in the pulmonary artery. Problem may be in the lungs or the pulmonary artery. We call it as pre-capillary because it is before the capillary, the pathology is there. Post-capillary means after the pulmonary capillaries, pathology is there. That is in pulmonary veins or the left heart. So if my pulmonary vascular resistance is more than 3, that means pulmonary artery is also involved and the left heart is also involved. So we'll call it as pre plus post capillary defect, post capillary cause. That clearly indicates you have left heart disease. And if pulmonary vascular resistance is normal, that means there is no RAS activation. In that case, I would think of pulmonary vein occlusion as the cause. Pulmonary vein occlusion as the cause. And if I have this pulmonary arterial hypertension, as we know, it is purely a pre-capillary defect because the problem is in the pulmonary artery, not in the left side of the heart or the pulmonary veins. So this is how we interpret the right heart catheterization data. On this, I will share some MCQs on the Telegram after the class. So go and solve that. Hopefully you will be able to get the gist of how we approach the right heart catheterization data interpretation for the MCQs. Okay, now having understood, that brings us to the last part of the discussion, that is the management of pulmonary hypertension. Okay, how do we manage a case of pulmonary hypertension? Let us go by groups. What is group 1? That is pulmonary arterial hypertension, right? What is group 2? It is pulmonary hypertension due to left heart disease. What is group 3? It is pulmonary hypertension due to, right, lung diseases or due to hypoxia. What is group 4? That is chronic thromboembolic pulmonary hypertension. And what is group 5? That is all miscellaneous or multifactorial causes. Now, so please remember, in all these conditions, if I have mitral stenosis, right, how can I improve the patient's pulmonary pressures? If I give vasodilators or something, it may not do much of a difference. Best thing is relieve the mitral stenosis. Right? If I have interstitial lung disease, try to treat the lung disease. So for all these, treating the underlying cause is the main treatment. Treat the underlying cause. But when it comes to pulmonary arterial hypertension, it is a primary disorder, right? We do not have a secondary, something else as a reason for pulmonary arterial hypertension. So we need to approach it differently. So we'll understand how to approach the pulmonary arterial hypertension. So in pulmonary arterial hypertension, first let me make a list of drugs available. What are the drugs available to treat? So pulmonary arterial hypertension, I have to relieve or reduce the pressure in the pulmonary artery. When we have systemic hypertension, right, what all drugs we use? We use drugs like calcium channel blockers, right, ARBs, AC inhibitors. So how calcium channel blockers are going to help the systemic hypertension? They cause vasodilatation. So blood vessels constriction increases the pressure inside them by Boyle's law. By dilating it, I can lower the pressure. So same thing we can apply to the pulmonary circulation also. We can give either vasodilators or we can block the vasoconstrictors. See, why are we giving ARBs or AC inhibitors in systemic hypertension? Because the angiotensin 2 causes vasoconstriction. We are trying to block it. Now, what is the role of RAS in the pulmonary hypertension? Minimal. That typically happens when you have the left heart disease. Otherwise, in pulmonary hypertension, there are 3 key pathways involved. Key pathways involved in the pathogenesis of pulmonary arterial hypertension. What are those? The first one, just like we have RAS for the systemic blood pressure regulation, we have endothelin 1 for the pulmonary hypertension or pulmonary blood pressure regulation. Endothelin 1. Okay. Then we have another one which is nitric oxide pathway, and we have a third one which is prostaglandin I2. Prostaglandin I2. So what normally endothelin 1 does? Endothelin 1 causes pulmonary vasoconstriction. It causes vasoconstriction. And what nitric oxide and prostaglandin I2 do? They cause vasodilatation. Vasodilatation. So if I have to treat pulmonary hypertension, what should I do with the endothelin 1? I have to block it, right? By blocking, I can achieve vasodilatation and reduce the pulmonary artery pressure. What should I do with the nitric oxide pathway? I have to increase its activity so that I can achieve vasodilatation. Similarly, what should I do with the prostaglandin I2? I have to increase its activity so that I can achieve the vasodilatation. So when it comes to drugs available, right, first category that I should be talking about is endothelin 1 receptor blockers. Can anybody give me examples for endothelin 1 receptor blockers? So under this we have drugs like bosentan, ambrisentan, and macitentan. Ambrisentan and macitentan. So these are the endothelin receptor blockers. By blocking the endothelin 1 receptors, they can cause pulmonary vasodilatation. Okay. Second, how can I increase the nitric oxide pathway activity? How can I increase the nitric oxide pathway activity? So please remember, from which amino acid nitric oxide is formed? Nitric oxide is formed from arginine, right? Arginine gets converted to L-citrulline with an enzyme called as nitric oxide synthase, releasing the nitric oxide. Okay. And this nitric oxide, once released, causes, as we know, it will cause vasodilatation. But after release, it is quickly getting deactivated by an enzyme called as phosphodiesterase 5. Phosphodiesterase 5. So if I want more and more nitric oxide activity inside my pulmonary vasculature, I have to block the phosphodiesterase, which inactivates it. So which drugs can block this phosphodiesterase 5? These are quite famous drugs, right? Famous drugs. What are those? Like your sildenafil, tadalafil, what you call as Viagra and similar class of drugs. They are phosphodiesterase 5 inhibitors. So I can use them. Phosphodiesterase 5 inhibitors. Like, was it very good? Very good. Sildenafil or tadalafil. Sildenafil is something that we recognize as Viagra. Okay, yes. I can also increase. See, this nitric oxide causes vasodilatation through cyclic GMP. So I can increase the cyclic GMP production by stimulating guanylate cyclase. So I can use guanylate cyclase stimulator. Can anybody name which drug acts by stimulating the guanylate cyclase? Which drug acts by stimulating? That is riociguat. Riociguat. Okay. Then I have a fourth choice, which is increase the prostaglandin I2. Now I cannot directly or easily increase the prostaglandin I2, but I can give drugs which are very similar to prostaglandin I2, right? We call them as prostaglandin analogs or prostanoids. That will be my fourth class of drugs. Prostanoids. Can anybody give me examples for prostanoids? We have examples like epoprostinol, iloprost, right? These are prostanoids. And the last and a very cost-effective drug is the dihydropyridine calcium channel blockers. Dihydropyridine calcium channel blockers. So I have these 5 class of drugs. Was it very good? Riociguat. So we have these 5 class of drugs. Now the question is, how do I make a choice? Should I start with sildenafil, tadalafil, double benefits मिल सकते हैं, or should I start with ET blockers, or should I start with dihydropyridine calcium channel blockers? See, when I look at all of these drugs, right? Dihydropyridine calcium channel blocker, classical example is our amlodipine, nimodipine. Damn cheap, right? I can get amlodipine for 2 rupees or 1 rupee also. Bosentan and all will cost like 200 rupees, 150 rupees per tablet. Ambrisentan is even more costly. Macitentan is even more costly. Riociguat is damn costly. Tadalafil is damn costly. How do I make a choice? So Tapa, very good. How do I make a choice? Very good. So I think Wazir had already mentioned the decision making primarily depends on whether amlodipine can help the patient or not. If amlodipine can help, I will definitely use amlodipine. If amlodipine cannot help, then I have to think of other choices, right? So for that, we have to do a test. So if you have diagnosed anyone as having pulmonary arterial hypertension, then we do a test called as vasoreactivity testing. Where do we do it? We do it inside the cardiac cath lab. So when we are doing the right heart catheterization to measure the mean pulmonary artery pressure, that time, after measuring the mean pulmonary artery pressure, see, to call it as pulmonary arterial hypertension, it means mean pulmonary artery pressure is already more than or equal to 20 millimeters of mercury. Pulmonary arterial hypertension है मतलब it is pre-capillary, so PCWP will be less than 15 millimeters of mercury, and obviously pulmonary vascular resistance will be more than 3. If you want to remember the units, it is called as Wood units. So we will do a vasoreactivity testing where we will give a vasodilator. So in the vasoreactivity testing, we administer a vasodilator. What vasodilators I can use? I can use either inhaled nitric oxide, which is a potent vasodilator, or I can give IV ipoprostenol, or I can give IV adenosine or IV adenosine. After that, what I do is I will recheck the patient's mean pulmonary artery pressure. I will recheck the patient's mean pulmonary artery pressure. Now, two things are possible. Either the mean pulmonary artery pressure decreases by more than or equal to 10 millimeters of mercury to a final value less than 40 millimeters of mercury. In that case, we will say the vasoreactivity testing is positive. If it does not fit into these parameters, then we will say it is negative. So if it is positive, the initial treatment will be dihydropyridine calcium channel blockers. So every time I recognize a patient as having pulmonary arterial hypertension, I will pray to God saying that the right heart catheterization data and the vasoreactivity testing, let it come positive, because I can manage my patient's pulmonary hypertension cost effectively by simply giving amlodipine. But if it turns negative, then we have to think of drugs like the phosphodiesterase 5 inhibitors or the guanylate cyclase stimulator like riociguat or the prostanoids. The choice obviously depends on the severity of the disease. Okay. Now, understanding this is the main part. So I will give you one MCQ, and with that we will be done today. Let me see how many of you have understood this. Again, I will summarize. If I have recognized the case as pulmonary arterial hypertension, I will do a vasoreactivity testing. First of all, I would have already recorded the baseline mean pulmonary artery pressure. Then I give a vasodilator like inhaled nitric oxide or IV epoprostenol or IV adenosine, and I will recheck the mean pulmonary artery pressure. So if it is dropped by more than or equal to 10 millimeters of mercury, and remember, the final value should be less than 40 millimeters, then the test will be declared positive. If these two parameters are not met, the test will be declared negative. So I will give you 3 examples. I have a patient A, patient B, and patient C. So patient A had the initial mean pulmonary artery pressure of 62 millimeters of mercury, and then after the vasoreactivity testing, it has become 41 millimeters of mercury. Okay. Patient B had mean pulmonary artery pressure of 55 millimeters of mercury. After vasoreactivity testing, it has become 38 millimeters of mercury. And patient B had mean pulmonary artery pressure of 42 millimeters of mercury, and after the vasoreactivity testing, it has become 36 millimeters of mercury. So among these 3 criteria, for which category, like which patient you will start with the calcium channel blockers, and for all which other patients you will start with other drugs? So can I say the last C, is it vasoreactivity testing positive or negative? Is it positive or negative? Kushigar, yes, absolutely right. So is it positive or negative for C? So what is the parameter? Whatever is your initial value, the drop should be more than or equal to 10 millimeters of mercury, and the final value that it is reaching, it should be less than 40. Then only it will be called as positive. So the option C, the final value is less than 40, but the drop is more than or equal to 10. It is not, right? The drop is only 6. So this is negative, right? This is vasoreactivity testing negative. Option B, 55 to 38. How much is the drop? 12 and 5, almost 17 drop. And the final value is less than 40. So this will be counted as vasoreactivity testing positive. This is vasoreactivity testing positive. Very good. And option A, huge drop, right? Almost how much? 19 plus 2, 21 drop. But the final value is not less than 40. To call it as positive, final value should be less than 40. So this will also be counted as vasoreactivity testing negative. So only it is the patient B who can be started on the dihydropyridine calcium channel blockers. For every other patient A and C, I should start with either phosphodiesterase 5 inhibitors or prostanoids. Clear? So this is how we make a choice, and questions are mostly asked around this only. They will give you the data, they will give you information about the vasoreactivity testing. You should interpret and then decide what drug you would be starting for the patient. So that is one important MCQ zone. So that's it for today on the pulmonary hypertension. On this, we will run a Telegram based quiz maybe in the next Friday. This Friday, we are running a Telegram based quiz on ARDS. So please do participate. And today also, I will share some MCQs on the topic on the Telegram, and I expect that most of you should be able to answer it. Okay. So signing off, guys. See you soon. Till then, have a. Was it okay? I forgot to mention. Wazir, most of the students who are following me are second year, third year, or just the final year students. I'm not addressing much of the interns through this Harrison series or the PGs. But yeah, so if you're interested, I will also tell you how do we assess the severity in pulmonary hypertension and how do we predict the mortality. So assessment have certain clinical pointers like presence of the right ventricular S3 or patient having syncope or hypotension. They indicates that there is poor prognosis or the pulmonary hypertension is severe. If the right ventricular failure signs and symptoms are there, pulmonary hypertension is severe. But early on in the course of a case of pulmonary hypertension, we assess the severity primarily focusing on, apart from echo and other parameters, by looking at what is called as 6-minute walk distance. How much a person can walk in 6 minutes? Okay, how much you can walk? Most of us can walk. Sudhapa will address that. How much we can walk in 6 minutes? How many meters we can walk? See, most average individuals, right? They can comfortably walk 1 kilometer in 9 to 12 minutes. So in 6 minutes, you should be able to walk more than 600 meters comfortably. But if a patient is not able to walk more than 165 meters in 6 minutes, that means their prognosis is going to be very poor. They have more advanced or severe form of pulmonary hypertension. Right. You should be able to walk roughly around 600 meters. But if you're not able to do more than 165 meters, then we will count it as severe pulmonary hypertension. Okay. Sutapa, you had one last query, right? Why C is negative? See, to call it as positive, we need to meet two parameters. जो भी पहला एमपाप था, उससे 10 मिलीमीटर से मर्क्यूरी ड्रॉप होना चाहिए और ड्रॉप होने के बाद जो फाइनल मिलता है हमको वो 40 से नीचे होना चाहिए. तो यहाँ पे क्या हो रहा है, फाइनल तो 40 का नीचे है लेकिन ड्रॉप कितना है, ड्रॉप इज नॉट 10, राइट, ड्रॉप इज ओनली 6. 46 to 36 इज ओनली 6 मिलीमीटर ड्रॉप. तो ड्रॉप भी 10 होना चाहिए, फाइनल भी लेस देन 40 होना चाहिए. ओनली देन वी विल कॉल इट एज पॉजिटिव. So that is why we are not calling it as positive. Okay. So with that, signing off. I'll see you in the next class. Next, we will start with systemic hypertension. That will be a natural continuation. Till then, have a good day.